So our next session will be on pancreatic cancer.
All right. I hope you still have some little bit of ATP left. That's some energy source so that we can continue the last session, which is on pancreatic cancer. It's my great pleasure to introduce Dr. Howard Crawford to introduce the speakers for this session. Dr. Howard has been working on the subject of pancreatic cancer for more than 25 years. He's the scientific director for the Henry Ford Pancreatic Cancer Center in Michigan. Please join me in welcoming to the podium. Thank you.
Thank you. I'll be moderating this final session for the day, so thank you all for sticking around. Getting right to it, it's my great pleasure to introduce Dr. Amber Habowski. Amber got her BS degree at the Seattle Public University, her PhD at the University of California, Irvine, and is a current postdoctoral fellow in the Tuvison Laboratory at Cold Spring Harbor. I just have to say a couple of personal words. I met Amber several years ago at Cold Spring Harbor, and I can tell you, I can guarantee you, this is somebody who is so sharp and so passionate about what she does that what you're about to see is a rising star present. Thank you.
All right, well, thank you for the lovely introduction. It's quite an honor to speak here. Dr. Martella Rooney has been after me for a few years to actually come and speak. Every year we delay, hoping we can actually finish some of these projects, which, shocker, they're still not done, but we're working on it. So I'm excited to share a little bit of progress on some of these exciting projects. So you've already heard quite a bit of talk about pancreatic cancer, so that makes my introduction much easier. But one of the things I do want to highlight that hasn't been discussed as readily is how the 5-year survival rate has changed over the past few decades. And if you look in 1999, our 5-year survival rate was only 4%. And despite a lot of research from many individuals, we're now at a whopping 13, almost 14%. So several-fold increase, but this is still quite grim, and we want to do better for these patients. And one of the reasons this is quite grim is the limited therapeutic options. If you look at what the therapy used to be, it was really focused on monotherapy chemo. And in 2010, one of the first combination regimens was introduced. This is FOLFIRINOX. And then a few years later, another combination therapy, GMP, was introduced. Both of these have now become standard of care for PDAC patients. It's usually up to the clinicians on which regimen to choose. There's some debate over which one might be better. Maybe some have less toxic side effects and some better for some patients. However, we wanted to know head-to-head which one might actually be better and is there a difference? And so in 2010, we actually started the PASO-1 clinical trial to really evaluate head-to-head in a prospective manner which of these therapies is better. And at Cold Spring Harbor, one of our big interests in this was actually using a precision medicine approach. So really trying to see, can we identify which of these therapies are best for individual patients? Now, given the idea that every patient and every tumor is going to respond differently, we of course are very interested in ancestry component and the race and ethnicity background. So there's been quite a bit of discussion so far about increased incidence in Black patients. But one of the things I also want to comment on is the fact that there's actually rises in certain patients as well. So as with colon cancer and pancreas cancer, we're also seeing the rise in young patients. This is actually most notable in Black patients and in Hispanic women. And one of the things coming from a molecular biology perspective, if we want to study this question and start to look on a molecular level of what might be some of the underlying reasons for these, is we have a lot of research challenges to overcome. And one of those challenges is that Black patients are often underrepresented in omic data. So this graph here on the right is showing you several different cancer types, and the two bars are comparing what's in the National Cancer Registry versus what's in the Cancer Genome Atlas or sequencing data. Everywhere there's an asterisk is where there's a significant difference. And everywhere I'm drawing an arrow here is where there's significantly lower percentage of Black patients represented in the omic data. And not surprisingly, one of the cancer types that is affiliated with this is pancreatic cancer. So in pancreatic cancer, we have a significantly lower percent of Black patients and actually a higher percent of Asian patients represented.
Oh, sorry about that.
So this is already a starting issue, the fact that we have less representation in omic data. Now, studying this from a cancer biology level, we of course want model systems. So when we then look at model systems, we also have another research challenge in that Black patients are underrepresented in cancer cell lines. This is looking at the COSMIC database of over 1,000 cell lines, and we have very small percent of patients that actually have any African ancestry. And when we look at this database and we actually pull out all the pancreas patients, we have none, which is an even bigger problem for studying pancreatic cancer. And one of the other databases also pulled from this is called the NCI-60. And this is a group of cells that have been used to do common drug screens since 1990. And there's only 3 cell lines that have any African ancestry. So really, in these cancer model systems, African and Black patients have really been underrepresented for decades. So in the Tuvison lab, the model system we're quite interested in looking at is called organoids, or patient-derived organoids, PDOs. And this is a cell culture type of model that allows us to grow tumors in vitro in the lab. And these tumors are taken from patients and sent to our lab and processed and grown in a little plastic dish. And you can see there's these little jelly domes, and within inside each of these jelly domes are cells that we expand in a 3D manner to really recreate a little mini tumor. And as we see with diversity within patients and within tumors, the morphology of all of these organoids is different. So this is just showing you a range of different organoids and how different that they actually look. Now, using our organoid model system, we actually became a part of this PASO-1 clinical trial that I mentioned earlier. And this is a really special, unique clinical trial that's been extremely collaborative. So I'm showing you here all the different institutes that have been part of this trial. You'll notice there's sites across the US and across Canada. And at its core, this was a phase 2 randomized trial to compare, as I mentioned, GMP and FOLFIRINOX, those 2 standard of care chemotherapies. And this was focused on metastatic stage 4 untreated PDAC patients. We screened over 200 patients, and then once on trial, they were randomized to one of these 2 arms. And excitingly, after 4 years, we finally finished this trial. This summer, the first batch of data came out, and actually just last month, the clinical manuscript was submitted. So I don't really want to focus too much on the clinical data. I want to stay focused on the organoids and the precision medicine aspect. But just to give you a quick snapshot of some of the clinical data, this is looking at the survival curves of the patients on this trial. And interestingly, we actually had improved survival from the GNP arm over FOLFIRINOX, which was perhaps a bit different than what we'd originally expected. And one of the other things that wasn't as surprising is looking at the transcriptional subtypes of these pancreatic cancer patients. And so one of the ways we can classify pancreatic cancer is by the transcriptional or RNA expression profiles. And there's 2 main types, more basal, more aggressive versus more classical. And we see here the basal patients have worse outcomes. So now, looking into addition to the clinical part of this trial, what we were really excited about was the correlatives, which really allowed us to dive into these individual patients' tumors and study them on a molecular level. When patients were enrolled on this trial, they underwent extensive biopsies, and these biopsies were then used for several different purposes. Several of the biopsies were sent to Cold Spring Harbor for PDO generation and drug screening. Other biopsies went for whole genome sequencing, RNA sequencing, and then others for staining, and then also blood for ctDNA and CTCs. And this really allowed us to actually ask a whole host of different correlative questions to really probe and understand different features of these patients and their cancers. We were particularly interested, as I said, on the PDO side of things. So how do the patients and the PDOs look? What is the different sensitivities in the PDOs, and how does this correlate or perhaps even predict patient outcome? So looking at the trial in the whole and what we received at Cold Spring Harbor, we had over 186 biopsies that were sent to us. The vast majority of them came from liver metastases, but we also had a few other unique and rare sites, as well as some primary lesions. In terms of our generation, we were able to make PDOs from about 50% of the patients. This is in line with some of our historic work, but we are still working to try to improve those outcomes. So one of the first things that we realized is when we started looking at our PDO success rate and correlating this with patient outcome, is we actually saw a relationship between these. And so what I mean by that is when we were able to make the PDO, these tended to be patients that had worse outcomes. If we couldn't make a PDO, these were actually patients that had better outcomes. So once we did make a PDO for those patients, we then They then underwent what we call pharmacotyping. And this is a high throughput drug screening program that we've developed. This is all based on automated liquid handlers and allows us to do this in a really high throughput manner. We can look for over 100 different drugs and really see how do these organoids respond. The exciting part about this clinical trial is, and we had monthly molecular tumor boards where the patients were presented. Their clinicians often presented the patients, talked about their prognosis, how they were doing, therapy options. At the same time, the molecular correlates were presented. So we then talked about what happened with the sequencing and what happened with the organoids. And in some cases, the clinicians could then use this data to guide the second line therapy selection when patients progressed on first line. And then one of the things we're working on now that the trial's wrapping up is really trying to understand how predictive are these organoids. And so that's one of our ongoing areas. And just to give a little bit of a snapshot, one of the ways we can do this is by actually looking at the empiric drug screening data and then basically classifying organoids as patients that have organoids that are either a responder or a non-responder based on a signature to some of our standard of care chemotherapies. And what we see is the patients that have a responder organoid actually have improved overall survival and PFS. So when we then look at all of the patients that we've been able to make an organoid from, we can classify them based on the type of organoid and type of signature they have. So just to simplify it, we have 4 different responder categories of organoids. You can see that A and B are really kind of worse outcome, and C and D are a little bit better. And then when we actually look at the therapy selection of this, responder category C, patients that have this type of organoid actually do a little bit better on GMP, versus responder category D, they actually do a little bit better on FOLFIRINOX, which is quite interesting given the trial as a whole favored GNP. Now, I want to go back into the ethnicity and the diversity within this trial. You've seen several different percentages of clinical trials not having an immense amount of diversity. And I will say this trial on the whole, we did okay. Could have done better, but it's not actually too bad. This trial was really about half in Canada, half in the US. So given the smaller amounts of Black individuals in Canada, the fact that we have about a 10% Black population isn't too bad. And we're only about 70% white. And I think one of the advantages we had here is how many institutes were involved. So we're pulling from a large pool of patients, and we did have some minority serving institutions as well. However, one of the big problems that we face is this idea of how much diversity is actually within patients that are labeled as Black. So for some of our work that's really pulled from the US, often these patients get labeled as African American, which usually means they're self-identifying as Black and they live in the US. But for this study, we also have patients coming from Canada as well. We do sometimes get distinction on Caribbean, but we really don't get any further distinction on patients that are actually from Africa or with stronger African descent. And one of the reasons this becomes really important is there are very distinct mortality rates between African American or US born individuals and Afro-Caribbean and actually African patients. So just to actually show you a table of some of these mortality rates, this is normalized to white. On the top is male and the bottom is female. And you can see the African Americans, as has been mentioned before, have increased mortality rates, but Afro-Caribbean actually have lowered rates, and then African, with the exception of females, have lower rates. So it's important to actually look at the diversity within these groups. Now, we can break this down even more and look at West Central versus Eastern Africa. And surprisingly, when you break it down and look at this, you actually see African overall is lower, but it's actually West Central African that's really lower versus East African in men is quite elevated. And you actually see the opposite effect in female. So you're seeing very regional differences, and we're also seeing quite differences based on sex. So when you instead just lump all these individuals as Black, you're really missing a lot of heterogeneity and diversity. So what does it look like on my end? What is the data we get? So oftentimes for samples we receive, this is literally a screenshot of some of the data that we have. So we get told gender, male, female, and then in terms of race, Black or African American, sometimes Caribbean, and then we get Hispanic or not. And so, of course, country of origin is not included, and the race can be really a bit vague. And this is really only for the patients where we are receiving information. Some patients don't want to provide that, or in some cases, it's not collected. And so this is a challenge when you're trying to study this from a molecular perspective. And so one of the things that you've heard other people talk about as well is this idea of genetic ancestry. And so this is a fantastic tool that's been developed by several different groups, including one of our collaborators at Cold Spring Harbor. And this allows us to actually determine genetic ancestry from cancer genomes or transcriptomic data. And importantly, you don't actually need the normal data to run this algorithm. So the graph here is showing you an example of what this ancestry admixture looks like. You can see we have a handful of patients that are strongly of African descent, and then you can see there's some that have a mixed ancestry as well. We can also break this down to another level too and look subcontinental. So rather than just labeling as African, we can look at different regions of Africa, different regions of European, and actually get better granularity of the true ancestry of these patients. So our interest in this has also been a big part of the New York Genome Center funded Polyethnic 1000 project. This has been a very challenging project that originally was supposed to be a 1 to 2 year project. And here we are about 5 years later, hopefully nearing the end of it. But in this, we really set out to improve the diversity in our organoid biobank. And as I mentioned here, many biobanks, including ours, are really overrepresented by European Americans. And so we wanted to actually increase the representation of African Americans so we could look to see if there were molecular differences. And for this, we collected tissue at Northwell Health and at Downstate, established organoid models when we could, and then we did therapy testing, RNA sequencing, DNA sequencing, and importantly, wanted to keep these models and biobank them for future studies and to share with others. Now, as of today, we've actually made 43 models, pulling from this project and a few others. And so I think we're quite happy with this. And so we're still moving forward with sequencing some of these final models, but I do have a little bit of preliminary data that I'll show you. So one of the first things is we talked about the drug screening we do with these organoids. And so using this, we can actually start to compare, in this case, just Black versus non-Black, to see if we see any drug differences. And we have a few potential differences, but this is, again, very preliminary, and we have a lot of work we need to do on actually correcting the ancestry genetic component, as I mentioned before, and also looking and try to control covariates a bit better. But hopefully we'll be able to continue looking for these differences in drug screening and response. On a few of the patients that we have done DNA sequencing, we do actually see some differences in copy number variation. So this is comparing a few African American and European American patients, and we have some regions where there's potentially a difference in amplification and some differences in potentially deletions. So we'll do more work to see what are the genes of interest in these regions, but it could suggest some fundamental differences in the cancers between these patient populations. Now, finally, going back to look on the RNA level, I mentioned earlier that basal and classical subtype. And one of the things we've been looking at in the patients on our PASO-1 clinical trial is actually looking at a little bit more detail and trying to classify these different subtypes. So in this, we have 4 different flavors of pancreatic cancer, a little bit more complex than just the basal classical. And what's interesting is from these 4 different flavors, we actually have different PDO organoid success rates. Some of them were quite good at growing and some of them were quite bad. And what's also interesting is when we look at the self-identified race of the patients that are in these different groups, we actually have different representation. So we have increased representation of Black patients in certain groups and less representation in others. So we still have quite a bit of work to do on this and applying the genetic ancestry, but this would suggest there could be some RNA differences between these patients as well. So big takeaways, one of the things to say is our projects are not complete yet, but I hope you stay tuned. I think we do have some exciting things to come. We're really in the final phase of the PAS1 clinical trial and our PDO story there. And then we're doing the final sequencing for our P1000 project and all those African-American organoids we've been able to generate. And a few kind of, takeaway messages I want to say is one of them is it's important for us as a community to continue investigating the heterogeneity within the Black or African-American population and not just labeling them as one underrepresented minority, but really looking at the distinct differences between them. And tools like genetic ancestry can be really important in enabling that. And another one that I think is, kind of a hard truth to swallow, but is despite the effort from us and many other groups, we're still really underpowered to actually study many of these molecular questions that we're interested in. So we still need a lot more work here so that we can actually answer some of these questions we have. And finally, I want to just leave and say at the end that it's important to include diversity within all aspects of research that we're doing, be it on the more clinical side or in the biobanks and the omics data. But I will say firsthand, this can be something that's really challenging. A lot of the discussion today has been on like recruitment for clinical trials, but some of the same challenges that are faced there, we face in actually generating and collecting samples for biobanks. So, we've gone through this quite a few times of how can we improve recruitment of patients for biobanks and for research. But I think there's still a lot of room for improvement on this. And we need a lot of individuals involved to actually inspire and encourage increased diversity in preclinical research. So with that, I have a huge amount of acknowledgements. This type of research, of course, takes an immense team, and we have a fantastic team at Cold Spring Harbor, and also working in close collaboration with Northwell Health and Laura Martello here at Downstate. And then, of course, the PASO-1 trial as a whole had an immense amount of people involved, and it's really been a huge collaborative effort over many years. So, and finally, thank you guys for your attention.